All right, everyone. I hope you're enjoying this conference so far. This is sort of a grassroots type effort. It all started when we were discussing a few things about training in a Facebook Messenger chat, and said, "Hey, why don't we try putting on a live conference that's free for everybody?" So that's how it all started, and we then came up with a list of speakers that we thought could draw a crowd. And I'm sure that that is pretty evident by our speaker lineup if you're involved in social media whatsoever. I do want to reiterate that if you want to get CE for this, I am sharing a link towards the end of every conference. You can also, Dr. Lubbers was sharing an infographic for that, but all you have to do to get CE, to get a certificate, is click on that link, complete a short survey, and you should automatically get a certificate. If you don't see the link, or if the chat's too busy for that, all you have to do is go to curvetobed.com, and there is a CONED-19 certificate link in the menu bar, and just click on the speaker's name, and it should take you to a Google form for that specific lecture. Now, I do want to reiterate, this is not CAPSI approved. CAPSI costs a lot of money. This is a free conference. The speakers are donated their time, et cetera, et cetera. But we have heard from a few people that the National Registry is accepting any state-sponsored CE, even if you're not within that state. All right. Is everyone ready to move forward with the next lecture? I hope so, because this train is not stopping. Our next speaker is Tyler Christifulli with FoamFrat. I'm sure he probably does not need an introduction. You all are familiar with him, and he may be one of the main reasons you are listening right now. With that being said, thank you, Tyler, for agreeing to donate your time and share your expertise.
Absolutely, Floyd. Thanks so much for having me, man. I am getting some text messages from people right now saying, "Of course you have a helicopter as your title slide." There's got to be. I said it's just as much a picture of a fire truck that it is a helicopter. But Floyd's right. My name is Tyler Christifulli. I work as a flight paramedic, and I run with a great team, the Foam Frat blog and podcast. And I'm a relatively new flight paramedic. I've only been doing this for about 2 years now. And before that, I worked on the ambulance, a ground critical care truck in 911. And one of the things I really like about being a flight medic is we drop in at different places all over Wisconsin. I'm a cheesehead, and Minnesota. And we get to jump in the back of an ambulance during the middle of a resuscitation. And this may be a volunteer ambulance service. This may be a career fire department, but we jump in and one of us goes in the side door, one of us goes in the back door, and we do a quick evaluation, and we get to just lay eyes on the resuscitation process. And so what I want to talk about today is a particular case that happened recently. And so we had a patient that got T-boned. And as we're doing our high recon, we're kind of looking over, and you're trying to judge, all right, how bad is this going to be by what the wreckage looks like below. And we get down, and usually when we get there, they're already immobilized. Hopefully they have an IV placed. We kind of get lazy because the paramedics and the EMTs on the ground are doing the majority. They're the ones getting them out of the ditch, getting them into the ambulance, and then we just get to come in and do some of the cooler things like, intubate or whatever. But the majority of the work is being done by the EMTs and paramedics. And so this particular day, we jump in the back, and I look at the monitor and I see blood pressure 82/40. I got a heart rate of 125. Patient's 97% on room air, and they're telling me she has a GCS of 7. Now, this is a 68-year-old female who was sideswiped. She's got an unstable pelvis. She's tachycardic. She's got an elevated shock index. And the first thing I actually saw when I jumped in the back of the ambulance was a paramedic greasing up his laryngoscope, getting ready to go in and intubate. And he said, she's got a GCS less than 8. We have to intubate. And, because it rhymes. And he said, her pulse ox is fine right now. We're going to start pre-oxygenating her. We're drawing up the meds, and they were getting ready to go through with this intubation. Now, you may be looking at this and maybe you're catching on and you're saying, all right, I've heard the term, you got to resuscitate before you intubate. But what does that mean? Does that mean we give some fluid, or are we trying to get their shock index below 0.9? And their shock index is just their heart rate divided by systolic blood pressure. What is our goal? Are we going to actually get this person not tachycardic? We're probably going to be intubating in a low flow state. Should we even intubate? And so I'm doing a quick assessment of this because I don't want them to push these meds yet, because a patient is kind of moaning in pain, but there doesn't appear to be any life-threatening airway issues. Everything seems to be below the belt, but we do a quick assessment. We come in with our ultrasound. We got bilateral lung sliding. I don't see any bleeding in the abdomen. It looks like we're isolated to the pelvis, which would make sense with where she got hit. I said, I want to hold off on intubating right now. Because my thought process is that as soon as we induce her and we put in a sedative agent or we paralyze, this patient is going to crunk on us. We're going to lose our blood pressure, and we could very well be doing CPR. Why is that? Why do I have that in my head? Do these vitals look horrible to you? Maybe not the worst, but I want to show you some of the physiological changes that happen when you intubate somebody. And I put this together in a quick and short talk called The Sound of Silence, the Sound of Sedation, Trauma Anesthesia. Now, I'm going to tell you that trauma anesthesia is almost all about venous return. It's all about gradients. And I say almost because if you can get the blood back to the heart, typically the heart's healthy enough to pump it out to the rest of the body. The majority of the stuff we talk about in trauma is just getting that blood back to the heart. We're plugging holes and looking at venous return. Now, can you have cardiac issues? Yeah, absolutely you can. But it's almost all about venous return, and understanding how these front end pharmacokinetics work has a lot to do with the venous return gradient. And so that's what we're going to talk about. All right, so on the screen here, you can see we have an arterial going through a capillary bed and into a venule. This is the smallest artery, and this is the smallest vein. And what's interesting is as you go through this capillary bed, you lose pressure. We know that the arterial side is not as compliant. We got more muscle around it. And then we get over to the venous side, and it's relaxed. It got more compliance. It's kind of like a big spongy pool of blood, and it can hold a ton of blood. The majority of our blood supply is on the venous side. And if we looked at the pressure gradient between these two, we would notice that, we're looking at systolic and diastolic here. And you can see a huge contrast between systole and diastole right as the blood is ejected from the left ventricle. But as you go through the arteries and then the arterioles and then the capillaries, you see we get this pressure drop. And that's because we went through that capillary bed. We went through those tiny little vessels. You're going to lose some pressure with that. And then we're entering in a big pool, the venous capacitance system. And if you looked at how this pressure gradient works, this is the way it has to work. It has to go from a higher pressure to a lower pressure, because that is how you create flow. When you can flow from high to low. If I have a pressure of 5 on this side and a pressure of 5 on this side, I have a static environment. I don't have flow. That's how you create wind, is by dropping a pressure here and having a higher pressure here. And this is all about venous return, is getting that gradient and making sure you maintain that gradient. Now, I'm going to show you an illustration here that you can do on the back of a napkin at a bar and explain to somebody what the effect of positive pressure does on a patient, and then what the effect of our medications that we give and how that affects venous return. All right, so let's say we got this patient laying flat on the ground here. And we're going to say that the pressure of the venous system, not the central venous pressure, but the right when you're coming out of the capillaries and you're going to the venules and then the veins, if we were to just put in a transducer in a vein, what would that pressure be? And so you'll hear some people refer to this as something called the mean systemic filling pressure. And the mean systemic filling pressure is actually a pressure that's theoretical if you had no flow. So if I stop my heart and I just let all of the blood kind of equalize, what you would find is that the venous side doesn't really rely that much on flow from the heart. You can take the pump away from it and the pressure stay pretty much the same on the venous side. And that's just because of how much stretch it has and how compliant it is. So let's say that we put this transducer in the leg and we just put it in a vein. It's said to be around 7 to 12 millimeters of mercury of pressure. All right, so that's the pressure here. Now, my goal is to get the blood to flow back to the heart. So what do you think this pressure would be here? If this pressure was 7, would that be good or bad? Well, obviously, that would be a static environment. That would be a milieu that does not promote flow. But we know that our right atrial pressure can be anywhere from like 0 to 2. We want it to be on the lower side. And so that's also known as your central venous pressure. We want that pressure to be lower because it promotes flow from the peripheral venous system back. All right, so now I'm going to throw in this little graph here. So for a certain peripheral pressure, it allows us a certain amount of flow. So this right here is my mean systemic filling pressure, or my peripheral venous pressure. And then this right here we'll say is my right atrial pressure. This is the downflow pressure that this has to overcome. So with 1 and 7, I am promoting flow back to the heart. Hope everybody's following that so far. So right here, this is the blood coming back, and this is the downstream pressure. Now watch what happens. Let's say that I take a patient and I put them on a ventilator. And let's just say I increase their thoracic pressure and it goes up to 5 millimeters of mercury of pressure. So I'm going to put my little 5 right here. If I keep my mean systemic filling pressure the same, this is what happens. So you can see I go up, and look at the drastic reduction in flow back to the heart I get just because I increased my right atrial pressure while maintaining the same mean systemic filling pressure. Now, here's what's interesting. In a trauma patient, what do you think this mean systemic filling pressure does? When you're losing, and we have to be specific, and we'll say that this is a hypovolemic trauma patient that we're talking about, but we're losing pressure here and we're losing volume. And so what happens is this pressure starts to work down as well. And imagine this patient that I jump in the back of the ambulance. They have a blood pressure of 80/40. Their heart rate is high. They're trying to compensate. I take away a significant portion of that gradient. Now we can start to see why when you intubate a patient that has a super low blood pressure, you're changing those gradients. And imagine now if this mean systemic filling pressure was 5, and then I put them on positive pressure, we've lost flow and the patient goes into cardiac arrest or becomes profoundly hypotensive. Here's another way of looking at it. So here's my systemic filling pressure on this side, and this is my right atrial pressure. If these are both the same, I have no flow. So how do I create flow? Well, I can either get rid of the pressure on this side on my right atrium, but eventually I'm going to run out of flow as well because this is going to gradually decrease until the patient doesn't have any more blood in them. So now imagine I'm putting blood back in here. I'd also have to open this up. So you have to have a gradient in order to maintain that flow. And so this is assuming the little spigot on this side, the faucet, is assuming that the patient's heart is working appropriately. But we can also see why you can't really go off of the shape of the IVC to tell the status about the fluid status of the patient. Because if for some reason the spigot isn't shooting the fluid out, I'm going to back up as well. And then if I look over here, this does tell me about my systemic filling pressure, but it's in relationship to my cardiac output, which usually trauma patients have a pretty decent cardiac contractility. One of the things I noticed when I started utilizing ultrasound is if I throw the ultrasound on a trauma patient, it is collapsing on itself. It wants more pressure. And that's what I want. It wants more volume, I should say. And that's what I'm watching for. If I look and I see a trauma patient with a heart that's barely moving, I need to start thinking about what other causes there could be. But the main takeaway from this is that you have to have a gradient. So I think that when we look at a patient, we should start looking at them in fragmentations, in segments. So imagine we have to get that blood from here up to the heart. How do we do that? How do we get those? And we split these up into these little segments here. And we have the abdominal section it has to go through, and then we have the thoracic quadrant that it has to go through. And so we'll say that, let's just say this is Sam right here. And Sam doesn't have any airway issues at all. He got shot a couple times, but he's got bilateral lung sliding on ultrasound. And it looks like he's just got hit right here in the spleen, and maybe got a kidney got hit as well. So we're looking at him and we see that his, we're just going to assume that his mean systemic filling pressure is like 7, because we said that was a normal value. And right now has negative pressure breathing. So that's really good, because that's keeping that right atrial pressure nice and low. So what are the things that would decrease his mean systemic filling pressure? Well, let's look at that. So we'll say that the first one, and the one that's the most obvious to us, would be hypovolemia. If he's bleeding out, there's no doubt that I'm going to be dropping this number. The second thing is sedation, because you have a certain amount of adrenergic tone when your body has that heavy metal song playing in the background. When you give them the sound of silence and you relax them, they lose that tone, and your venous system becomes more compliant. And when it becomes more compliant, your mean systemic filling pressure, your peripheral venous pressure drops, which means that this number up here needs to drop as well, or I'm going to lose my gradient. All right, what about paralytics? Yeah, so the majority of your, I shouldn't say the majority, but a lot of your venous return depends on the valves, making sure they keep the same direction going, and the muscular contractions as well of your body. If I paralyze the muscles, I'm going to drop my mean systemic filling pressure. So these are all the things that happen when we intubate somebody. And then we can throw in hypovolemia, intubating a trauma patient. And so when we're looking at this side of the equation, we really have to say, is it worth it? Is there anything wrong with his airway? Can I put him on a nasal cannula and tuck a suction catheter underneath his neck and protect his airway until we can get a couple units of blood in? And I'm not going to sit and wait in the back of the ambulance to get those 2 units of blood in. We're going to start heading to a trauma center. And so I have really started to weigh the consequences of intubating a patient and switching them to positive pressure ventilation. So let's look at what positive pressure ventilation does. So we're going to say that right now he's got a right atrial pressure, we'll say 1 millimeter of mercury of pressure. And if I throw him on positive pressure ventilation, that immediately increases that pressure. Now, it's not a perfect linear correlation between your right atrial pressure and your PEEP, but as you increase PEEP, you do increase thoracic pressure. What else? RV dysfunction. If somebody's got a sick RV, you're not going to be able to pump that blood efficiently out. It's just like the spigot that's not working as well. And then pulmonary resistance. And so if somebody's got sick lungs, these are other things that are going to increase that right atrial pressure. The main one for trauma is positive pressure ventilation. But if I do notice that I have a pericardial tamponade, obviously that's something that needs to be taken care of right away. And that's the benefit of doing a rush exam as opposed to a fast exam, is you're looking at everything. You're not just looking for free fluid. So here's the question: how do I increase this pressure? If I need to intubate this patient right now, how do I do it? Well, I'm going to ask you guys, what is the best pressor in trauma? And so people argue it's either, it's Levophed or it's epinephrine, push dose epi. And now I think we're having growing evidence that vasopressin is probably a good agent, just because our body has a fixed secretion of vasopressin that doesn't really fluctuate depending on stress. Now, in the setting that you absolutely have to intubate somebody right now, I'm going to talk about that at the latter portion of this in just a few minutes. But you really got to weigh out whether it's worth intubating them at all, because the best pressor in trauma is negative pressure breathing. And I think of this like a Super Soaker. And I went way back on this. I got the Super Soaker 100, and I never had this one, but maybe one of you guys watching this had this. And so I was thinking about how the Super Soaker works. And if I say this is the venous system right here, and then this is going to be my IVC, and then this is my right ventricle, the way that I pool blood into the heart is by negative pressure breathing. So by the act of me going and dropping my thoracic pressure, I'm actually like giving my heart a bolus of blood, and I'm pulling that blood back into the heart. And you can actually see this on ultrasound. You'll see variations in the IVC. So the patient takes a deep breath and they go, and you see that IVC collapse, and then they comes back out. And so I wanted to experiment with this. And so I took the ultrasound, and I had the nurse I was working with put me on CPAP, and we dialed up the PEEP until I saw no variation in my IVC and almost passed out. And you can see that the IVC, I'm going to show you here in just a second, was not fluctuating barely at all. Now, in the beginning, it was. But as my thoracic pressure starts to get closer and closer to what that mean systemic filling pressure is, I lose that gradient. And this is really a fun experiment when you're talking about this and the downfalls of intubating, or I shouldn't say the downfalls, but really the consequences of intubating a patient. So what happened here? Well, let's just say my intrathoracic pressure increased to 5, and that reduced the flow. And so this is my IVC right here, and this is on 10 of PEEP. So it's not supposed to look like that. That's what you would call plethoric. You would say that that is a plethoric IVC, meaning that it looks full and it's not really varying much with ventilation. All right, so I tricked you before by asking you what the best pressor was, but now I'm going to actually ask you, what is the best medication? If you're going to induce a patient that has a low flow state, which one of these is the best? And so everybody right now is going ketamine, ketamine, ketamine is the best, right? And it's interesting. My buddy Brian Winchell did a talk, and he really stressed that it's not the medication, it's the dose. And so this is interesting to watch on Twitter too, because there's this belief that ketamine automatically increases everybody's blood pressure. You give somebody ketamine when their blood pressure's in the toilet and you need to sedate them or whatever. And that just couldn't be any further from the truth. And I'm going to show you a conversation that took place on Twitter. And I didn't take out the names because nobody said anything really like bad or anything, but I just think it's interesting to see this. So this guy says, isn't ketamine best utilized in the hypotensive patient requiring intubation? I've never seen it causing hypotension. And so then Haney Malame comes through and he says it definitely can at full dose. Definitely the least hypotensive of the bunch, but can still cause with a shock index greater than 0.8. And so then we have this Farm D that comes in, and he says, I don't agree with this statement. The physiology of the patient doesn't determine the dose. The depletion of catecholamines is, and of itself, the reason that the patient is hypotensive. Ketamine, regardless of the dose, can't make a patient more depleted of catecholamines. 0 can't be less than 0. Now, here's the problem with this statement right here. Ketamine is a direct myocardial depressant. It's a direct myocardial depressant. You're going, no, it's not. I've seen it increase blood pressure. The reason it increases blood pressure is because it increases the catecholamine surge. So you get increased chronotropic response. You get increased peripheral vascular resistance. And that makes up for the crappy squeeze that the heart has. But if you look at the heart when somebody's on ketamine, it is not beating on all cylinders. It's a direct myocardial depressant, and that's very well documented. You can just look that up, type in ketamine's effect on cardiac contractility. And so what happens is if you have a patient that is depleted of catecholamines because they're bleeding them all out on the floor, and you don't have that to counteract the myocardial depression, then all you get is the myocardial depression and your patient's blood pressure drops. So does this mean that we don't give ketamine? No, not at all. But it means that the difference between medicine and poison is the dose. When you're giving a medication, you have to ask yourself, what is the target organ for this medication? And so with a sedative, the target organ is the brain. Well, the patient is being peripherally squeezed. All the blood is trying to prioritize the vital organs, the organs like the heart and the brain. And so imagine here, I got my little brain in this monster. It's getting squeezed from all the endogenous catecholamines. And then I go and I give some ketamine. That ketamine doesn't have to have that normal distribution pattern. It goes straight to the brain. It gets to the brain right away. And so because of that, we don't need large doses of ketamine. Now, somebody I remember put on Twitter one time, in a shock state, you have to go low on your sedatives and higher on your paralytics, because paralytics, their target is the entire body. Like, it's got to get to all the muscles. And so when you dose your paralytics, you're thinking, if I'm in a low flow state, I need to increase my dose of paralytics. Well, they just got criticized up and down. I can't believe you're intubating patients and not properly sedating them and then increasing the paralytic dose. And somebody with that mindset obviously doesn't understand front end pharmacokinetics and how that works, because you get the same brain levels with a reduced dose of your sedative, because you don't have the normal distribution. It's not going into all the fat. It's not working its way into the rest of the body that you figure on when you talk about a dose of 2 to 3 milligrams per kilo of ketamine. When you're talking about inducing somebody with ketamine in a low flow state, you're talking 0.5, sometimes to 1 milligram per kilo. Now, obviously, just because I say this doesn't mean you go run and do it, but this is something that definitely needs to be addressed. If you've had situations where you give patient ketamine and you notice their blood pressure drops, consider what the dose was and what type of flow state they were in. So I made this graph. This is the influences of gradient, and I can definitely send this to Floyd. He can disseminate this to everyone who signed up. Actually, I don't want to put that on you. If you guys want this, hit me up on Twitter at Christifulli88. Otherwise, go check out FoamFrat Facebook page or foamfrat.com, FOAMFRAT, and I can send you guys this, and I have a recorded version of this talk as well. So there you go, guys. That is the Sound of Silence trauma anesthesia. It's all about venous return, and we got to start thinking about patients in regard to gradient. Thank you.
Thank you, Tyler. Do you have time to take some questions?
Yeah, absolutely, man.
All right. If you have a question, just please type it in the Q&A section.
And then I think I can see that on my end, right? If they ask a question.
Yeah, I think you can.
Okay, cool.
If you click on the Q&A window.
Awesome. Thanks a lot, man. He says he works in the London Trauma Center. Man, that's got to be gnarly. There's a study being done right now by Dave O'Vera, I think Air Methods, called the Viper study, looking at vasopressin and trauma and hemorrhagic shock. And I think that'll be interesting to see how that comes out. Thanks a lot, Charlotte. I appreciate it.
Wasn't there a recent study released on using vasopressin in trauma?
So yeah, there's a study by Carrie Sims called the AVERT trial, and they were looking at if they had a reduction in how much blood they gave if they started vasopressin. And the problem is to extrapolate anything from that to pre-hospital, the patients had already gotten 6 units of blood before they even considered using it. Very wide confidence intervals, but one thing it did show is it did show the safety profile of vasopressin, and there wasn't any badness that happened from giving vaso, so that was kind of cool. Hey, thanks a lot, J-Rod. Appreciate it, man. I can't believe I dissed ketamine a little. Nobody's going to come at me. It's because of Howie's talk. He set me up. They're all like, nope, not going to have no fireback response.
Yeah, a lot of people are afraid of giving any sort of pressors in trauma because they're afraid the trauma surgeon or ER physician will yell at them.
I did a I don't know if you read my blog I did called the Levophed Assisted Transfusion. And it was kind of just a thought piece. But, I think there are situations where you can augment it while you're giving them product. And I've had situations where patients have a a head bleed or something. And I think you can augment some of that mean systemic filling pressure while you're giving blood with a low dose levoephedrine. But there's absolutely no evidence to prove that. And so I probably shouldn't even say it, but I'm a big fan of the levo. I
Well,
like go
go
ahead.
ahead.
What?
I was just going to say, when the patient becomes peri-arrest and you're about to start CPR, you're going to be given a milligram of
Yeah.
epi really soon.
Well, I had a situation where, so we carry our blood in a cooler and we don't bring it into every hospital because usually the hospitals have blood. So we just keep it in the aircraft. And I've had situations where I go in and I'm like, oh man, we need blood like right now. And we send the pilot out to the aircraft to go grab the blood cooler. And in that process, I'm like, all right, well, what else can we do right now?
Well, this was an excellent lecture. Thank you very much. I don't think that we have any questions in the Q&A section. So, and everyone, this is streamed live on YouTube. So if you need to go back and watch any of it, you can. All right.
Oh, Russ, do you mind if I answer this one real quick? Or
Yeah,
we
go
were
ahead.
short on time?
Go ahead. No.
Russ said, so what was the outcome of the case? You began the presentation. Did you intubate or not? How was the patient's response? No, so we did not intubate. I sat there with a suction tucked underneath her neck, and we sat there and we gave 2 units of blood. We got to the hospital, and they didn't intubate as well until she went to surgery. I think they ended up probably intubating her. But no, she did fine. And if she would have vomited, I mean, I can sit there with a suction catheter. Dentists put people under anesthesia all the time and don't intubate them. They just sit there with suction and watch them. And so you got to really weigh out the risk benefit ratio of changing up those gradients. But thanks for asking, Russ. I guess I should have included the end of that. I see Julie just said this is from Dane. Oh, okay. Tyler, you have more tools than the average ground paramedic. If you were on a truck versus a helicopter, how would this information change your practice? Yeah, so I mean, I think the only thing that I have that you guys don't is probably ultrasound in a ventilator. And the thing is the body's gradients don't change, and I can't tell anything about mean systemic filling pressure from ultrasound really at all. And so you just have to theoretically like put into theory what you think is going on. So if my patient's bleeding out, their mean systemic filling pressure is probably dropping. If I intubate them, the right atrial pressure is probably increasing. And so if you got a patient that you really have to weigh out whether or not this is worth intubating and knowing the things that can affect that. And if you don't have a way of increasing that pressure, I would do everything I possibly could to not intubate. Do you think we intubate unnecessarily in trauma? 100% I do. Yeah, I do, because of things like GCS less than 8 intubate. That's in everybody's head. Well, they're going to get intubated anyway at the hospital for surgery, so we should probably just do it now. And I just don't. I guess I don't buy into that, because by the time we get them to the hospital, I can have them significantly more resuscitated with product, and not have to just do that right there in the back of that ambulance. And I think that, yeah, they probably will get intubated at the hospital, but there's a lot more resources there that they have access to, like a level one transfuser, and hopefully you can resuscitate them more before you get there. Yeah, and Floyd, I think somebody else said that too, that it says it's not accepting submissions.
Yeah, so Dr. Lover set up the forms, and he is helping Dr. Hinckley prepare for his next talk right now. The easiest way to access these links, rather than me sharing them in the chat, is probably just go to curbtobed.com, and there's a link in the main menu for CONED 19 certificates. Someone just said it's working again. I do apologize for this issue, but you can always go back. We're going to troubleshoot it. Dr. Lovers might not be able to get to it right now, but he will as soon as he can. Yeah, someone said, so we have a lot of international participants, and it seems like some of our international folks are having issues with this. Please keep checking back. If you keep having issues with it, then send me an email at curbtobed@gmail.com, and just make the subject line something like certificate link not working, so that I can flag that. Okay. Looks like a few people are able to get in now. Anyway, we'll take a short break and let Dr. Hinckley set up. And Tyler, if you want to, I think you might be able to keep answering some questions in the Q&A section.
Yeah, I'd be happy to. If you guys have any other questions, and I just stopped sharing my screen, so Dr. Hinckley can add his if he needs to. But yeah, if you guys have any questions, feel free to throw them in there.
Excellent. Thank you, Tyler.
Yeah, absolutely, man.
Also check out is it foamfrat.com?
Yeah, foamfrat.com. We have a podcast and then a blog as well.
Excellent. We definitely want to let the speakers promote their own product and their own website, since they are doing this for free. So please check that out.
I'm going to put my Twitter in here. I was looking over here on the I'm looking at the chat, and I see the are you worried about giving cold blood to trauma patients causing hypothermia? Yeah, I'm extremely worried about that. I won't. There's no benefit. Well, I'm going to start speaking in indefinites, but I don't think there's any benefit in giving blood if it's cold. That doesn't make sense to me. We use the Q-Flow Warrior, which takes ice cold water and turns it in. It feels like it's like nice, like I don't know, I want to say it feels like urine because that's a weird illustration, but it comes out at body temperature, and that is our go-to. Before we had the Buddy Light, and the Buddy Light, I think it kind of sucked. It wasn't that good at all, but the Q-Flow works very well.